So the summaries of our sensor fires. There's a strong repeating pattern, as I just mentioned, every evening in the autumn and winter as we turn our heating on. There are always localized events, although there can be strong agreement, which is reflected in the general weather or the pollution forecast. And there's approximately one serious pollution event every 10 days or so. And there's a 20% correlation between indoor and outdoor. But one of the things that was striking for us was that indoor pollution increases going out of town. And the highest readings of indoor pollution come from suburban areas of Belfast, where there are more houses with more stoves and more open fires. And summary of our prescription findings, well, we found a relationship between diabetes and respiratory prescriptions, which disappears when you filter out deprivation, because people in deprived areas are more likely to suffer from multiple conditions. In deprived areas, there's a 165% increase in general of spending than when compared to the wealthier areas. And there is a seasonal increase in respiratory prescriptions in wealthy areas that isn't reflected in deprived areas. So what can we do about it? What action can we take? And what we realized working through this project, that the hard problems are usually human problems. They're not technical problems. Changing people's behavior is just hard, it's difficult. Look at the legislation that was introduced to ban smoking in the workplace. Consider how long it took us to get there. How many decades passed before public opinion had shifted just enough for the government to risk banning smoking? What is the likelihood of the government banning stoves or heavily taxing cars so that they cannot be a source of pollution? It just seems unrealistic. So we really need to look at how we can change behavior and recognize that it is difficult. Now, there are roughly 2 articles a week in the national newspapers about pollution and its impact. The screenshots you see in front of you, I took just last week. I didn't have to hunt very far. It's a selection of newspapers from across the UK. And there are initiatives around the UK to promote this awareness, but general anecdotal evidence is that they are underperforming. So let's look at what we are trying to achieve. And again, these numbers are for Northern Ireland. And for those of you living in England, you just need to do the mental maths, multiply by 30. What we want to do is provide personalized, localized, and real-time actionable advice. We want to create personal positive asthma action plans for up to 150,000 patients across Northern Ireland. We want to reduce the 10,000 critical care admissions that happen every year and reduce those 70,000 bed days that are an impact are caused by those 10,000 critical care admissions. And we want to reduce the £45 million spent on respiratory medicine each year. These are the targets, these are the goals, and this is how we measure our success and whether or not we can impact these numbers. Now, we reason that the most likely people to engage with pollution and health services, applications designed to change your behavior and inform you, they're probably not the people that need the most help, but they are the easiest to reach. So, for example, an application that services the parkrun community or the Strava users, who you would find a group of people that are very engaged with their health, and they're very welcoming for more data, for training and health guidance. And yes, they're not necessarily the people that you need to, they don't need intervention, but they can be a route to refining a service, building evidence so that we can target more vulnerable groups. Ideally, what we would like to do is reach people through their GP-led care. There is no reason why a service, an application like the one you can see in front of you, which is Clean Air for Healthcare's mobile application, there's no reason why that couldn't be prescribed by a GP. But to do that, to reach the GPs, you have to refine the service, and you have to test it in the real world, and you have to have a slick experience and clear evidence of its effectiveness. So why not target the people that you can reach and use them to improve your application, improve your messaging, and improve personalized care that you can possibly offer by localized pollution information. An example of this would be Couch to 5K, which isn't for everyone, but it is an example of a really successful self-help application that is promoted actively by the NHS and is recommended by the NHS. Now, we're aware of various initiatives to use existing pollution data infrastructure to deliver air quality alerts. And as I mentioned before, anecdotally, there just doesn't appear to be a huge take-up. So we need to work on that problem. So, as I said, behavioral change is hard. And we are working with the University of Ulster on an ethical study to understand how people react to personalized pollution information. What are the ethical issues, and how might they affect people's behavior? Now, it's an ongoing study, so I really don't have results to discuss at this time. And we're also having conversations with behavioral experts discussing how we might involve communities to target vulnerable groups. Could we, for example, provide real-time feedback in parks? Can you put a sensor in your local park and information on the gate that might change behavior? How would it change behavior? Could you encourage people to walk rather than run on a day with bad pollution? Could you remind people who do have long-term respiratory problems to take their inhaler before they walk the dog, because they might, or maybe delay until a later or another day? So, and finally, we're continuing to expand our geospatial hub into other services and look at how it can help work with on other health and social problems.